Hello, it's Dr Beth Colby from Talk Mental Health, and I'm a psychiatrist in London. This is my talks regarding Keira Bell taking the Tavistock and Portman NHS Trust to court regarding their Gender Identity Development Service. They then went on to talk about the evaluation paper on the early intervention study at the Gender Identity Development Service, when a meeting paper was summarised, although it had not been published in a peer-reviewed journal, and this was the result. The reported qualitative data on early outcomes of 44 young people who received early pubertal suppression. It noted that 100% of young people stated that they wished to continue on GnRHA, that 23, that's 52%, reported an improvement in mood since starting that blocker, but that 27% reported a decrease in mood. Noted, and this is in bold, there was no overall improvement in mood or psychological well-being using standardised psychological measures. It was then stated that it was not for the court to decide between clinical disagreements about the efficacy of a treatment. But then it said, however, the degree to which the treatment is experimental and has as yet an unknown impact does go to the critical issue of whether a young person can have sufficient understanding of the risks and benefits to be able lawfully to consent to that treatment. The claimants also submitted that there is good evidence that for a significant proportion of young people presenting with gender dysphoria, the condition resolves itself through adolescence without treatment with puberty blockers, and that puberty blockers actually serve to increase the likelihood of gender dysphoria and therefore could be positively harmful to the child or young person's long-term health. And that according to DSM-5, the American Psychiatric Association's Diagnostic and Statistical Manual version 5, in quotes, in natal males, persistence of gender dysphoria has ranged from 2.2% to 30%. In natal females, persistence has ranged from 12% to 50%. It was then stated that the figures needed to be treated with caution as the cohort of people in this study was younger than those who would normally be treated by the Gender Identity Development Service with puberty blockers. The Dutch study argued that adolescents who show established gender dysphoria rarely identify as their biological sex. It was stated there were two reasons for this. One, that the diagnosis of persistent gender dysphoria was correct, or another one was that the fact that somebody had a diagnosis and a course of treatment, this affirmed the diagnosis. That is, both gender affirmative psychotherapy and the use of puberty blockers. And this solidified the feeling of cross-gender identification and led young people to commit to sex reassignment surgery more strongly than they would have done if there had been a different diagnosis and treatment. In the next section, there was evidence from Keira Bell and other claimants of their experience of being prescribed puberty blockers and cross-sex hormones, and there are a few pages on this. In section C, there were submissions. Was that a child or young person under the age of 18 are not capable of giving consent to puberty blockers? And the secondary case is that the information given was inadequate to form the basis of informed consent. There was a third issue that was raised in writing. This was that if any person under the age of 18 is prescribed puberty blockers, their case should be referred to the Court of Protection. It was stated that the Court of Protection would have no jurisdiction to consider such referrals. It was stressed that the claimants were not calling into question whether gender dysphoria existed, nor questioning the extreme distress caused by gender dysphoria, or that puberty blockers should never be given to people under 18, or that it was never in their best interests for it to be prescribed. The central issue was whether those under the age of 18 can give informed consent. They then went into case law about giving contraceptive advice to children without parental consent, and the concept of Gillick competence. And there were pages and pages of different court cases. The lawyer for the claimant submitted that in determining whether a child is Gillick competent, the court should consider what a reasonable person in the patient's position would understand, and said that in asking that question, the reasonable person is one with adult knowledge. However, the defence submitted that when deciding what information needs to be given to the patient and understood by them, the test is a reasonable person in that individual's position, i.e. a reasonable 12-year-old or other age with gender dysphoria. And she said that the salient information that needs to be provided is what that reasonable patient would attach importance to, and said that seeking consent, certainly for treatment with lifelong implications, such as one, for example, sterilisation, would involve some act of imagination. And she submitted that the court ought not to be pronouncing on hypothetical cases, but it should or could consider the facts of one specific case as and when it rises. The court then went on to state that a question is whether a person under the age of 16 is GILIC competent to make the relevant decision, will be able to consent to treatment, will depend on the nature of the treatment proposed as well as the person's individual characteristics. And where the decision is significant and life-changing, then there's a greater onus to ensure that the child understands and is able to weigh the information. They went on to state that a 7-year-old with precocious puberty would not be able to consent to puberty blockers, but that his or her parents must give consent because of the young age of the child and the intended nature of the treatment. Thirdly, it was stated that efforts should be made to allow the child or young person to become GILIC competent where possible, and that clinicians should work with the individual to help them understand the treatment proposed and its potential implications in order to help them achieve competence. Fourthly, it was stated that not every individual under the age of 16 will be able to become GILIC competent in relation to the treatment proposed. Fifthly, the court stated that in order to achieve GILIC competency, it is important not to set the bar too high. And they stated that the claimant's approach, the bar being very high for competence and capacity, was contrary both to common law and to a child's Article 8 rights and the importance of supporting individual autonomy. The court then went on to say that a person should be able to understand an explanation of the information in broad terms and simple language, and that the child or young person needs to be able to demonstrate sufficient understanding of the salient facts. And they stated that in deciding which facts are salient and what level of understanding is sufficient, it is necessary to have regard to matters which are those which objectively ought to be given weight in the future, although the child may be unconcerned about them now. And on the facts of this case, there are some obvious examples, including the impact on fertility and future sexual functioning. The reason why I said more for the claimants than the defence is because the overall decision of the court was that children are not able to give informed consent to receiving puberty blockers. I hope this has been informative, and well done if you've got to the end of this. I will stop now and give the conclusions of the court in a separate video. Thank you for listening. Bye for now.